Right. Hello, I'm Ben Coleman. I'm a Deputy Leader of the Council, and I'm also responsible for health and social care in the borough. I have the honour of chairing the Health and Wellbeing Board. We're here today with lots of wonderful people from the Council, from the National Health Service, from the local community. We've just about got, I think, a manageable amount of people for everyone to introduce themselves. So I'm just going to call out names, if I may, as I see them on the screen. If you could just say quickly who you are, that would be great, so we can all know who we're talking to. Natalia.
Hello, good evening all. I'm Councillor Natalia Perez, Chair of the Health Adult Social Care Policy Accountability Committee. Thank you.
Wonderful, thank you. Sue?
Hi everyone, I'm Sue Rooston. I'm the Borough Director for Hammersmith and Fulham, part of North West London ICB.
Which is the NHS, yep?
Yeah.
For those who might know it, wonderful, thank you. Trish?
Hello, I'm Trish Longdon. I'm a local resident and a lay partner involved in the Hammersmith and Fulham Health and Care Partnership with all these other wonderful people on this call. And I also chair the Strategic Bay Forum at Imperial, so I have some links into the Imperial Hospital as well.
Well, thank you very much. Very welcome. Very good to see you. Lisa.
Hi, I'm Lisa Redfern. I'm the Strategic Director for Social Care, which also incorporates public health, leading on health and co-chair for the Hammersmith and Fulham ICP.
Great care partnership. And
yeah.
With the council.
Yeah.
Thank you very much. Sue Spiller.
Hi, I'm Sue. I'm from SOBUS, the local infrastructure organisation for the voluntary sector in Hammersmith and Fulham.
Brilliant, thank you. And welcome. Maria.
Hello, I'm Maria Connolly. I'm a local resident, a former carer, and I've been a patient representative with the GP Federation formerly, and involved at Health and Care Partnership in Hammersmith and Fulham as well.
Brilliant, welcome. Thanks for coming. Jackie.
Hi, I'm Jackie McShannon, a Strategic Director for Children's Services, and pleased to be here. Thank you.
And at the council, that is. I'm just because everyone wants to see me. Yeah, wonderful. Thank you. Jo.
Hi everyone, I work for the council as well. I'm the Assistant Director for Independent Living and Specialist Services and Independent Living in adult social care. Lovely to see you all.
Thanks, Jo. Great. Nikki. Dr. Lang, I should say.
Nikki Lang, Director of Public Health, Hammersmith and Fulham.
Wonderful, thank you. Angie.
Hi again. I work for Rethink Mental Illness as the Senior Project Officer.
Excellent, thank you. Thanks and welcome. Michelle.
Hi, I'm Michelle Roberts, Programme Lead in the Council's Social Care Commissioning team.
Brilliant. Hi, welcome. Carla.
Hi everyone, I'm Carla Colston. I'm a Children and Young People's Manager from Rethink Mental Illness.
Okay, great. Thanks for coming as well. Good to see you. Helen.
Hi, I'm Kinski. Sorry, if I come in too soon.
That's fine, please. That's good.
Oh, sorry, other Helen. I'm Programme Manager for the Health and Care Partnership.
In the NHS?
Well, partnership covers both, but I'm hosted by NHS.
Yeah, hosted by NHS. Yes, thank you. The partnership covers both. It's just people coming from different places. I mean, we're coming together. It's a big thing. Sarah. Sarah,
Director, Children's Commissioning for LBHF.
Thanks. At the council, yeah?
Yeah.
Thank you. All people have moved around on my screen. Don't do that. Linda.
Hi, Linda Jackson, Director of Social Care and Independent Living for Hammersmith and Fulham Council.
Thank you. Nadia.
Good evening, everyone. Nadia Taylor. I chair the local Health Watch Committee, as well as bringing to the board the carers perspective as chair of Carers Network as well.
Excellent. Thanks very much. Sharon Tomlin.
Good evening. Sharon Tomlin, local resident and a member of team member of SOBUS.
Marvellous. Thank you very much. And Luxan.
Oh, good evening. So, Detective Inspector Luxan Thuray Ratnasingham. I'm with Central West Public Protection and I'm the police representative.
It's good to see you. Thank you very much. I have to say, it's very nice. Luxan, appreciate you coming to these meetings. It's good to have the police at all these meetings. It makes a big difference. We really appreciate it. Thank you.
I think I missed the invite on the last one.
Yeah. Noted. Thank you. Shad.
Right. Shad Hyberton, Deputy CEO and Head of Engagement Partnership at Sobus.
Thank you very much. And Helen. You're on mute.
Yeah,
Great.
sorry. Helen Mangan, Deputy Director at West London Trust.
Right, and that's the mental health.
That's
NHS,
mental health.
NHS, yeah. Thank you
And
very
some
much.
community, yeah.
Some community, yes, yes. Thank you very much. Good. So we've got a few things to get through and to talk about, interesting things. First of all, we've got the minutes of the last meeting. But no, sorry. Can I just check first of all? Sorry. We have any apologies for absence? Forgive me, I should have asked that. Bathsheba. I should have introduced. This is Bathsheba Moll, who's our clerk, and in parallel.
Good evening, everyone. So we have some apologies from Chris Hilton, Dr. Chris Hilton, and also apologies from Philippa Johnson. We've got apologies for lateness from Rob Hurd and Carleen Duffy. And we've also got apologies from Hafson, who I know aren't on the board, but obviously they'll be joining us. So hopefully they'll be with us soon as well.
Right, right. I'm just thinking I've got two councillors who are hoping to come tonight. I'm wondering if the councillor Sanderson and Councillor Rowbottom, and I'm wondering if they're vainly searching for a Teams link. Maybe you could just send them both the Zoom link. Yeah.
Yeah, I'll do a reminder.
Because they haven't noticed that. Okay, great. We've got the minutes of the last meeting. I hope everyone's had a chance to look at those. Are there any corrections to those? Okay, and any matters arising from them? I wonder if I could just pick up a couple of things, really, that it talks about vaccination, talks about monkeypox and things like that. I would just wonder, Dr. Lang, Nicola, if I could ask you to just say a little bit about how the vaccination's going in the borough, and also just very briefly, people have been a little bit concerned about the possibility of diphtheria or illness among asylum seekers placed in the borough, and also what the situation is with regard to strep A and antibiotics, whether they're available.
Sure. So monkeypox cases have gone down significantly since the summer. And as Councillor Coleman says, the big thing is now vaccination. We're preparing and getting ready for the second round. So people have 2 monkeypox vaccinations. So that's a positive story now. We're moving towards getting people vaccinated, which is really good. And again, working with our sexual health services and our voluntary and community sector to do that. In terms of diphtheria, we haven't had any cases in the borough. So these are the media reports that you've seen. There is a lot of diphtheria in Europe. So the danger for people who are making their way to us through Europe is they either have it in their home countries and are infected as they come, or they catch it when staying in a camp in Europe and then bring it in that way. And we saw there was a tragic death of a migrant, which they're still working out whether diphtheria was the cause of death. Again, not in the borough. We've had amazing work from the NHS in the Northwest London, you could call it Integrated Care Board. They are going through all of our asylum hotels and giving diphtheria vaccine, and then where relevant, if people have been in Manston camp 10 days ago, they get a course of antibiotics. So our hotels were visited from the 26th to 27th of November, which was a weekend, whichever dates those were. So we're very grateful to Sunita Chauhan, Lily Wong and colleagues for doing that. And there's a lot of work going on in our asylum hotels to make sure that everyone is registered with a GP and has all their health needs met. So thank you.
How do you think that's going, Nikki? Is that going well?
Yes, it is. So all of our gentlemen are registered with Brook Green Medical Practice. They've had lots of in-reach visits from Sharon Kay. So huge thanks to primary care. And now the young gentlemen now feel really confident. So they're now walking to the GP practice, which is, if you know Brook Green, it's just about 5 minutes away. So that's good. They're feeling that that's their GP and that's where they go. So that's been a good piece of work.
Very nice. That's very nice. Really appreciate that. Thank you. Thanks to the GPs
Thanks
and NHS for that. Yeah.
Yeah. And then in terms of Streptococcus A or all the news reports that you've seen, there is much more Strep A circulating. So there are many more cases than usual. Statistically, it's almost 3 times higher number of cases than in the last peak. So you usually get a peak every 3 to 4 years. The last peak was 2017 to 2018. So we've got a lot more cases nationally. Different theories that you've seen circulating in the media. One is social distancing during the coronavirus pandemic may have interrupted the cycle and then explains the current increase. There are different theories. Other theories are there's lots of viral co-infection, so people may have flu or even chickenpox and then be more vulnerable to group A strep, which is a bacterial infection. And then you'll have seen the scary things on the news, that's invasive group A strep. So this is very rare. And again, there's a higher proportion of invasive group A cases in children that we would normally see. However, it's very rare. In terms of what we've done locally, we've done, with great thanks to Jackie McShannon and children's colleagues, a lot of very effective communication to schools and to parents using our own messages, and then obviously relying on UK Health Security Agency. We've used social media as well. I met the primary care cluster heads last Thursday, and we've been working seamlessly with Connecting Care for Children, which is a way that Imperial Hospital works with our local GPs. It's a very effective way of, if you have a problem with something in the area, they all have come together. So I think Sue will correct me, it's Janet Cree plus a lot of, and Sue and pediatric colleagues came together quickly to establish a helpline for GPs as well. We've offered teaching out to all early years and school settings. There's now a helpline for schools and early years settings. And Councillor Coleman was involved as well. We've done some Twitter advice on how to get antibiotics.
So yes, what's the situation now with forgive me for interrupting you, but what's the situation with antibiotics? Are people able to get it, or we're going to have to follow the shop around until you find a pharmacy that has one?
I think there has, I'll defer to Sue, there's been guidance that came out on Friday, which makes it easier for pharmacists to change prescriptions. So there should be more flexibility now, they won't get punished. So the shortage was of the liquid syrupy sweet kind of penicillin, but I'll pass that one over to Sue.
Yeah, so there has been notification round to all of our GPs to sort of, where possible, prescribe tablet form antibiotics, which hasn't been as affected. The liquid form is definitely much more there's no issues with supply, but it is the delivery schedules and getting things to the local pharmacies. It should start to ease off as things start to sort of normalise again. There was a rush on over the last couple of weekends for sure, but there has been guidance out to all of our primary care colleagues. So hopefully people should start to sort of see and be able to access them as they need them again.
Good, thank you. I think it's helpful that the NHS changed the rules. I was listening to the radio, and there was this person saying, you know, they can't, if they're prescribed liquid form, they can't then give pills to be crushed, and I'm glad that the NHS has addressed that, so that it's easier for people to get antibiotics than it was. Good. Couple of quick things, Nikki. I was going to ask you about flu and COVID vaccination as well. That's just how that's going in the borough, or I don't know if you're the right person to ask, but I'm seeing the figures. I was looking at the figures again today, and they're rising. And there are people in Charing Cross at the moment, some like 90 people who have COVID and a few in intensive care. How is vaccination going?
Do you want me to pick that up?
Yeah, if you could. Thank you,
Sue.
So I think it is very much BAU for us. So obviously people have access through our pharmacies, and I know that Nadia in your team at the local authority is doing another pop-up, I think, at Westfield, possibly next week, for both polio vaccine and COVID.
Good.
So they are doing sort of various things to sort of try and encourage and entice people to still come forward. But it is very much a BAU scenario now. People, if they are eligible for their boosters, are obviously able to access that vastly through our pharmacies in Hammersmith and Fulham. That's probably where most people are going.
I realise people can access it, and it's great that it can be through pharmacies. What is the take-up like? Because I'm getting a little bit worried.
So the take up has, I mean, it's stabilised. It has dropped off a little bit in terms of, you know, in terms of the numbers that we were seeing for the first and second doses. But we are still seeing people coming forward for their boosters, and we are still seeing some that haven't been vaccinated before coming forward. So there is still the programme in North West London, but I have to say, Councillor Coleman, I haven't got the figures to hand for the latest ones. But we are, you know, we are still vaccinating people as and when people come forward for it.
So do you think we should, I mean, we're very happy to help with this, you know, before we did a lot of publicity. Do you think we should be perhaps considering doing some public information, some encouraging people? We've got the, we can put things back on. I mean, obviously it's not everybody's able to get the vaccine, it's people over 50 and other eligibility criteria.
Yeah.
But should we be doing some advertising to pushing this really quite hard? Do you think harder than we're pushing it? We can use advertising boards and things like that, and messaging on Nextdoor. Do you think it's time to do that?
I'm not entirely convinced that we would get a sort of a huge surge in people coming forward. But I mean, we that we've got set up that is talking about vaccines, which has sort of representation from all parts of the system on. So I will ask them to consider it and look at the take-up rates and see what additionality we can bring. But happy to do things as part of the winter programme. But you know, there was obviously the autumn booster campaign advertised at the beginning of was it September or October? I can't remember now. So yeah, so we are, I mean, but happy to do what people think is necessary.
I think with numbers going up, it might be a good time to remind people that they can get a booster. I think they'll want to get it. They might have forgotten that they can get it. I'm obviously we want to do things across North West London, but as always, I'm mostly concerned, and as I know everyone here is what happens in Hammersmith and Fulham. So the advice I think we need to consider for ourselves is what we do in this borough. I would be minded to push it.
So I'm happy we can pick that up as part of our vaccine group, and we can have the conversation there so that we can take the measured approach. Just to let you know, Councillor Coleman, that Rob Hurd and Janet Cree are waiting in the lobby. So I don't know.
Are they? That's super. If you'd let them in, please. Thank you so much.
Just text me, feeling lonely in the lobby.
I want them to join the club. Join us.
Yeah. Here they are.
Here they are. Here they are. We'll just let them come in. Rob, welcome.
They're in.
And Rob, hello, Rob. We've got lots of people in the meeting. Welcome. Thank you for joining us. And Peggy,
apologies, I was just checking I was in the right place.
No, you were. It didn't pop up on my screen. I don't know if it popped up on Bathsheba's that you were coming in. Rob, would you just be very kind? I'm not going to ask everyone to introduce themselves again, but if you could just say who you are, please.
Good evening, everyone. My name's Rob Hurd. I am the Chief Executive of NHS North West London, known as the Integrated Care Board.
Thank you very much. And Janet, might you introduce yourself as well, please? Welcome.
Sorry, I apologise. I couldn't unmute. I'm struggling with my technology. Janet Cree, I'm Chief Operating Officer at NHS North West London as well.
Thank you very much, Janet, and welcome as well. And Peggy, would you like to introduce yourself?
Unmute. Hi. I'm coming. I promise.
We can see. You can speak if you have problems with your
I'm
screen.
Peggy Coles. I'm the coordinator of the Hammersmith and Fulham Dementia Action Alliance. So
Wonderful.
There's Janet. Hi.
Janet. So we're all here together. Thank you very much. We were just finishing on the minutes, and we've just been talking about vaccination. That's good. One thing I just want to mention, because I'd like it recorded, is that on the final, just going back to a tiny little thing, is we were disappointed when it came to the latest group of asylum seekers who were placed in the borough. We didn't know about them. And indeed, we asked the Home Office, Linda, you asked the Home Office on, I think it was the 14th of November, if we had any being placed in the borough, and they said no. And at the same day, the Member of Parliament, Andy Slaughter, received a letter telling him they were being placed in the borough. We didn't find out until 3 days later, formally. So the Home Office is just repeating, I have to say, its usual way of behaving, which is not perhaps the most efficient way any of us would like. Someone's got their hand up and it went down. Who was that?
Sorry, Chair, it was me.
Yeah,
just to also say for the record that we've raised concerns with the Home Office about the level of care and support that the asylum seekers are receiving, including the food and the cleanliness of the home. We're waiting for them to come back, and hopefully they're coming to visit next week, but still not heard anything as yet.
Wow. Really is. It really is. I was very pleased with those who just joined us. You missed Nikki telling us about the remarkable work that local GPs and the NHS and she's have done going into the hotels. And I think Nikki talking to people one-to-one and making sure that they were healthy and safe. And that's, of course, I'm very grateful you did that, because that not only protects the community, but quite simply, it's kind. And that's what we need to be to people. And I have to say, the Home Office, kindness isn't the first thing on their list, it seems to me. But Linda, I look forward to your report after they come into the borough. Good. Okay, well, if there's nothing else on the minutes, we'll bounce on, which brings us to the Better Care Fund. And I'm going to ask Linda if you'd be kind enough to introduce that and say what's been brought to the board and what you're looking for from us.
Yes, thank you. I'm not going to go through the report in any detail because I'm going to assume that people have had a chance to read it, if I may. Just to say, we need the board to sign this off formally. The Better Care Fund is a way of pooling budgets between ourselves and the NHS. It, unlike the next fund I'm going to talk about, it enables us to work together in more of an integrated way to improve hospital discharge, but also how we stop people becoming patients in the first instance. So there are schemes in here which cover mental health, learning disabilities, older people. There are schemes around reablement, around domiciliary care. People may note that in the domiciliary care, we've made reference to the new support at home service, which is what our home care service will be called in the future. We're retendering that, doing a lot of really proactive work with our health colleagues, and there's a whole list of things that we're asking the care providers to do in an integrated way to support health colleagues, so it reduces the reliance on community nursing as well. So it's a split fund of just over 52 million. And there is a breakdown in the paper, and it allows us to work on a number of metrics, including reduced length of stay, how many people are avoided going into hospital, how many people are maintained at home 91 days after being discharged. So it's a really good way, a good starting point, I would say, and I'm sure Lisa and Sue and Janet and Rob would agree, a starting point that we need to build on the future, and perhaps we'll come on to that in our later conversation about what difference it makes for residents in that. So I wasn't planning to go on any detail, but I'm happy to take questions if anybody has any.
About any questions or comments? Yes, Sue.
Can I just ask, though, the services that this will fund, are they existing services or are they new services?
No, a lot of these are all existing services.
They're all existing.
Yeah.
Okay.
Yeah. Okay. Sue Risson.
Yeah, just to add that this was submitted, I think, sort of late September, wasn't it? And as part of the sort of national round for Better Care Fund submissions, we were fortunate that we didn't have any sort of key lines of inquiry coming back. So the national team are happy. I also believe Rob signed it off. So it is just a case of getting the sign off from the Health and Wellbeing Board, and then we can get the formal letter from the national team to say that we're good to go. But bear in mind that this is only up until the end of March, and then we start the process again.
Yeah, and I think it does follow a national template, but this is our opportunity to pour local flavour on it. So Better Care Fund is spent in different ways in different authorities, all on similar priorities though.
Thank you, Sue Riston. Oh no, sorry, Sue Speller.
Yeah, so I'm just wondering if there's any opportunity there, because I was looking at sort of the priorities, what it's for funding in terms of looking at sort of prevention in the community, because I know a lot of the services are already sort of the crisis point of response, but obviously we would argue that the voluntary sector could help with some of the preventative angle of this. Is there any opportunity to kind of get involved in what this would fund for next year's round earlier in the process?
So I think there's an opportunity to get involved in through the ICP, the Borough-Based Partnership, about how we fund prevention and early intervention. But this is one avenue of funding. there are several strands of funding, including the 3 SIF monies that we have as a council, which already support a lot of third sector development. It did used to fund some third sector monies in there. There was something in there for Red Cross, which is now funded through a different stream. But yes is a long answer to your yes is a short answer to your question.
Good. Any other points? I just think I just want to pick up what you said, Linda, about support at home. And there is this issue which we raised at the last Health and Wellbeing Board about carers, council carers, being asked effectively to provide clinical support at home that they're not trained to give. And we're still concerned about that. How far is this Better Care Fund program, if that's the right word, going to address that?
Yeah, so it's part of our negotiations with our, it's mainly our community health colleagues that we've been talking to about how they provide training and oversight to the domiciliary care staff. So there's a whole programme of training which will be implemented as part of the new contract.
Yeah, we don't have to. I mean, it's just if you're going to training and pay and all these things come together, don't they?
Sure.
If we're being asked to do effectively nursing at home and with carers who aren't trained for that, it's a difficult situation. Thank you, though, Nadia.
Thank you very much. Just very much along the same vein of the discussion just now, I just wondered whether you were aware of any strikes of staff that may well be providing or involved with domiciliary care. I know that physiotherapists or some physiotherapists will be on strike, and that may affect the occupational therapy provision. So I just wondered if you had any data as yet.
Okay.
So in terms of social care, no, we don't. I'll probably look to Rob and Sue and Janet to talk about NHS staff. I can't comment on that.
Rob, yeah.
Yeah, sure. So as I say, well, I'm not cited on social care staff, but we have 5 organisations across London, including Imperial and London Ambulance Service, where we are having to put in mitigations on the strike dates, which are not in the top of my head, but there is one coming up certainly on the 20th of December. And apologies, I wasn't ready for the question. I haven't got it in front of me, the other strike days, but we have a whole set of contingencies around industrial action and a whole set of processes of those services we will obviously keep running in the NHS during that period. And the tension is around what's called the derogations to make sure that we are not opening services that essentially we do need to downscale to respect the industrial action process. So that is, but Sue might be able to help me out on local impact, but we certainly have those organisations that have voted for industrial action all have contingency plans to keep services flowing, certainly the urgent services flowing through that period. But of course, it's going to have impact on non-urgent services.
Thank you.
I think the strike days, I think, are this Thursday and the 20th. So, and there's 2 organisations. So I think it's Imperial that have reached the sort of, but again, they're managing and having conversations about how they will mitigate against the impact for that. And then I think it was one of the community providers that doesn't affect us because it's sort of one of the outer boroughs.
Yeah, I think the relevant ones are Imperial and London Ambulance Service for your borough. Both of those have contingency plans in place, and because there is not more widespread strike action, we're able to do mutual aid within the rules around derogation to make sure the services keep going.
And I think the LAS is at the 21st and the 28th of the LAS dates, I believe. So
yeah.
Thank you both. That's reassuring to know.
Thank you, Nadia. And I'm going to add, seeing as I and Councillor Perry are the only politicians here, I'm going to make a point which everybody has to say absolutely po-faced to, which is it does seem to me ridiculous that the government is not talking to the unions properly and staying and hiding behind, it was the national, I can't remember the term it is, but the recommendation that they've been given on what the pay should be, which was made last year, and they don't have to stick by. I think it makes it all very much more difficult for everybody. They won't even talk to the unions. However, there may be things going on which we don't know about, and I only have to hope so, because it's very worrying for residents the situation, and it's very challenging for all of you in the NHS. And I really appreciate Robin and Sue and everyone, the work that all of you doing to try and keep residents safe. But you know, it will have an obviously, for what you just said, an impact on operations, and it's a bad time. We don't need it as a country. But we have a government which won't talk to the people whose services we so badly need. Anyway, we're going to move on. I think without any other comments on the Better Care Fund, I take that as we're all happy to accept that. And Bathsheba, presumably I sign that in person at the appropriate time, or is there another way in which we make it official?
The agreement noted as a recommendation in the minutes is sufficient.
Okay, wonderful. That's good. Then we've done that. Thank you very much. Which brings us on to the hospital discharge fund. Linda.
So, thank you. That's me again. So unlike the Better Care Fund, this money was money that the government announced in July to support adult social care, discharge more patients from hospital. As people have seen on the press, there's lots of discussion about reasons why people are delayed in hospital. One of those reasons is adult social care provision, but it's not the only reason. However, what we did get, and very gratefully, we received an allocation from Theresa Coffey towards social care, and it is adult social care, and it's only to be used to discharge patients from hospital. So again, there's the level of detail in the paper. It was given in two strands. So the first amount of money it was 500 million across the country, and that equated to just short of 16 million for North West London. I think it's fair to say also, in fairness to my NHS colleagues, that they worked really hard on this across London, because there was actually some of the money was capped for London. We're not really sure why, but that's at a national level, it's not at a local level. The allocations were given in two parts. There was one part, 40% was allocated directly to adult social care, which Hammersmith and Fulham's amounts are detailed in that. Just over 700,000 was given, 765,000 was given directly to adult social care, and there was a further 8.6 million allocated through to the Integrated Care Board, of which Rob is the chief exec. So we've outlined how we were going to spend that money. Well, I have to say this was done really well across North West London, and thank you to colleagues on this call who helped me facilitate some of this. So we agreed across all 8 boroughs with the North West London how we would allocate the money. We agreed 40% was to be spent on domiciliary care and reablement, 40% would be on step down and residential care, 10% would be spent at a local level, and a further 10% would be spent on improving quality of residential care. And that means those homes that requires improvement, that we would work across North West London to understand what could we do to help them make the next step into good for CQC outcomes. And again, likewise, from a CQC perspective at a London level, we've had really good engagement from them. So it's really been really helpful. Of course, that's just to get us to the planning. The proof of the pudding is in the delivery.
Yeah.
Health and Wellbeing Board are asked to sign off the allocation, just as we are with the BCF. So the one thing I would say in this, that there was a meeting today with the minister, and there were several conversations about how this was allocated. Should it all have been allocated to local authority? The one big area I feel has been a weakness in the guidance is they won't let us use the money for step up. So that would be, how do we stop people going into hospital? And we do a lot of that in Hammersmith and Fulham. We do a lot of prevention, stopping people going into hospital. We're not able to use this money for that. So I think, of course, on top of this, hospital discharge is a small part of what adult social care also deliver. So it doesn't cover all of the demands on adult social care. So I'm going to stop there, Chair, and take any questions. Thanks.
Thank you. Thank you very much, Linda. That's very good. And I'll just say for everyone, we're not going to go through everyone's names again, but we've been joined by Meryl Hammer, who's from Hammersmith and Sabre NHS, and Jim Greeley, ditto, who's also on our Health and Social Care Policy and Accountability Committee. So good to have you both, Meryl and Jim. Thank you. So we have the hospital discharge fund. Thank you for setting it up very well. Linda, Sue, you'd like to add something?
Yeah, just to add to it that I think there is a requirement for fortnightly monitoring against the sort of delivery and the expenditure based on that would need to sort of go through up to NHSE, and I think that goes, Linda, I think you're coordinating that, aren't you, on a fortnightly basis? There's a template, there's always a template that needs filling. So yeah.
There's always a template.
Yeah.
Yeah. Okay, thank you. And Rob, you'd like to add something?
I just want to highlight the two key imperatives for this money. Number one is obviously the immediate that's Linda's described and the good work that's taking place, but also if we can jointly show the impact, and although the templates are frustrating, it might give us the evidence base for why we want to get a more recurrent funding source, because this is a one-off for winter. We're now in December. We've only just been told what it is, and the money's, I think, only just arrived in local authority bank accounts on the 40% element. In the meeting I had before this with Linda's colleague Kerry, we've signed off all the proposed process, so we're not delaying it any further. So if you're signing off, but then we need to monitor, and it's about the impact, but it's also about the benefit of showing that impact as a case for getting recurrent funding increases for next year, because otherwise it stops in March, and that's a nonsense. Secondly, to Linda's point, because of a number of winter initiatives, because of the delay in them, if we've got any underspend, we will, we've just agreed a sort of weekly process to make sure if there are other things that can be done on the step up issues, and if it's a money blocking issue, then I'm very happy to facilitate, because it would be a nonsense if we're not spending money that we've been allocated, and and that we can keep those on the table, even though we've been directed not to use it for that purpose. It would be a nonsense if there are other things we could be doing in the months ahead. Thank you.
Yeah, no, that's really helpful. And Rob, thank you very much for all the effort you put into this and making sense of this. I have to say, and you're making a very good point about assessing the impact, because not only should we do that anyway, but it will help us make, as you say, help us make the case for more money next time. So perhaps that's something we could look at, and we might at the board, when the moment's right, look at actually the impact that it made and talk about that. That's very helpful. But yeah, it's good to have the money. There was quite a long gap between hearing about the money and but then there were several governments in between, so those things had to be sorted out. Thank you. Meryl, you'd like to come in?
Yes, it's probably nothing that, because this is a one-off funding, that anything can be done about. But there's a real issue, isn't there, about the level of pay of care staff, and how there's a high turnover as a result, or absence of staff. This comes up to HAFSON in a whole lot of contexts. I mean, we had a meeting with Tim Orchard today when we were talking about a range of things, but one of them was about discharge and about how care staff, be they care staff in homes or care staff going into people's own homes, can actually find better jobs that are probably less demanding in many ways. For example, in the retail sector. So it seems to me that that's an issue that at some point does need to be addressed fairly urgently.
Yeah, and I'm going to invite Lisa to come in, but I see she's keen to come in, so please, Lisa.
Yeah, you're spot on, Meryl, and that's been a central feature of the adult social care reforms that came in a year ago. As you're probably aware, the fair cost of funding aspect of it has been put on ice for 2 years. Over the country, people like myself and other colleagues have been working out what's called the fair cost of care for care staff, for care providers. But the problem is that until there's a decision, by government, by society, about how we want to fund social care, because it's the crux of it. Remember, I don't know if you remember the Dilnot Commission, 2011 gave us a blueprint, basically, as a country, for how to fund care. And until there's, and it's, you know, obviously very political, hence why no decision's been made. My own view, and I was talking to all the finance leads across London this morning about it. So in a way, and I'm, you know, it's a relief for local authorities that we're not implementing it, because we're not paid to do it. And when you're talking about £24 an hour for carers, for all the carers, we've got about 1,500, roughly speaking, across care homes and across social care. Phenomenal amount of money. I think it will bankrupt local authorities. That's not just my view. It's very, very bleak. Having said that, in Hammersmith and Fulham, we've been paying the London living wage for a very long time now. And I'm certainly not saying that carers shouldn't get that, get paid properly for what they do. That's not what I'm saying. The conundrum is, how will it be paid for as a country? So we're still in that position of, how can we, without me jumping on the campaign sort of step, how will we do it? And certainly that's now been, as I said, put on ice for 2 years. So that's my view. It's critical. In the meantime, however, I'll just finish off, Ben, if that's all right, with our new home care retendering that we're doing, and we have been working the last 2 years with health colleagues on how we can upskill our carers, create a career pathway to improve their lot, to hold on to good carers, improve retention, but also improve the experience of our residents and making sure they stay out of hospital, or they don't go into hospital in the first place. We've still got a long way to go. But that's it, really. I think.
No, that's very helpful.
To be quiet.
No. You've raised some really absolute top points, and the fact that, you know, we need to focus on improving the quality of the care that we provide. Giving carers a sense of job progression, which they don't largely have in many places, is absolutely essential. It's not me who said it. It was Jeremy Hunt when he was chairing the Health Select Committee. He's now the Chancellor. Obviously, we need more money in care. Again, you can all go silent face at this. We need more money in care. He talked in the autumn statement about difficult decisions. One of the difficult decisions he decided to take was to give us the difficult decision of whether we would raise council tax by an extra 2% to pay for care. I'd be very surprised. There'll be very few councils who don't take that up, simply because we can't not take it up, I think. And we're not talking about, however, new money to go into care for giving people career progression and training and things. We're talking about largely money that we need to take to stand still, because the government is not putting enough money into care. And of course, if you don't put enough money into care, you don't put enough money into the NHS, because we're so, as we've discussed, intricately involved in keeping people and getting people out of hospital and discharge. So, yeah.
Chair, sorry to interrupt you, Chair. There's a message in the chat if you'd like to see that.
I would like to see that. Thank you very much. Let's all rush to the chat. It does seem short-sighted, Trish Longson says, and not patient-focused, not to fund, keeping us out of hospital in the first place. Absolutely. This is it. And you have to, you know, the thing about care, we provide it as, you know, free in this borough. We're the only borough in the whole of the country that does that. And it is not as expensive as people fear it is. What is expensive is the fact that we constantly have to provide more care to everybody, because people have come out of hospital more quickly. We have to do two-handed care 4 times a day. And we have more people all the time who require care generally. That's what's costing everyone across the country more. And giving councils the opportunity to raise 2% to stand still is not what I call a difficult decision on behalf of the government. So let's hope they'll take some that they advocated when they were chairs of select committees before they were chancellors, and actually do something much more significant, which gives carers and councils the funding that we need to provide a proper service which supports the NHS the way that I know everyone in this virtual room wants. Forgive me again, abusing my position that I'm elected and don't have to can say certain things. But it is very frustrating, I know, for everyone, many people sitting here. That said, would anybody else like to comment on the discharge, the hospital discharge fund, before we take a decision to note it and approve what's been put forward?
Chair, can I just add one more thing?
Love you too.
Just to say that the points around complexity that you've just made are a key part of this. So, and it's really important that we understand the complexity of people's needs coming out of hospital. So we've seen an increase in the number of people coming out of hospital needing 2 carers 4 times a day. Of course, as we have that more and more, that means we're not able to give as much care to as many people. So as Sue says, we've got to report on this, but I think we've also said that we can't just focus on numbers. And the second part of this is, of course, it's very difficult when we do quite well in H&F about discharge numbers.
I know.
So it is really difficult sometimes to show improvement, but nevertheless, we're committed to.
I know. We're always talking about this. You work so well. The council works so well with the hospitals, and our social workers, and you do tremendously well at discharge, let alone reablement, which is fantastic. And it is difficult. I mean, it's almost as if we said, whereas there are other boroughs in other parts of London which don't show the same results. And for us, it's sometimes difficult for us to argue that we need the more funding, and we could do much better if we had more funding, because I think you're doing an extraordinarily good job already, but that doesn't stand in the way of the fact that we are doing it's more and more difficult all the time. And I think you do set that out well. Jim, can I bring you in? You got your hand up.
It's first of all, I think the council does a really astonishing job, and people from elsewhere keep commenting on that. It's a query to Linda or Lisa. We're talking about people coming out of hospital on discharge or keeping people out of hospital. Are they exclusively referring to the acute trusts, or are there also mental health bed discharges which have the same charge on the council?
So there is the opportunity to look at mental health beds, but however, I would say, Jim, that the majority of patients stuck are within the acute trust. There is also some extra monies around winter as well that we've also been allocated. And I know in the Better Care Fund, as I've talked about, we're spending in mental health. And the winter fund, there's some spending in mental health as well. It is a small proportion of discharges for this group, but we do have, because I attend the London meeting for discharge, what tends to happen is it's the delays for people with mental health needs in the acute trusts that are problematic, and people are not getting the right care in the acute trust. So of course we would always focus on how do we help people move on to the most appropriate placement who's stuck in an acute trust.
Thanks.
Great. Maria.
Hi, sorry, it's just I tend to think a bit like this, so forgive me. Can I just ask, there's talk about money going into the extra staffing, etc. Is there anything to say that the staffing will be available? I mean, it's great that there's any money, but sorry, Linda's smiling at me. I'm just thinking, being practical, there seems like there's going to be more pressure on getting people into the community. My fear is always that they're going to be sicker going out, so they're going to need more care rather than less. And also the holistic side of things, they're going to need, as Trish and I often say, they need their bread, they need their milk, they need, fundamental pastoral care. So I just wondered if the providers are saying, yeah, we can commit to this or not.
Good point, Maria.
So if I can come in on this, so this is where we have to be really clear that this cannot just be one-off monies. So the minister today very clearly said there is monies available in year 2 and year 3. And we actually said, we need that commitment to be able to work with the providers to say, you have got money here for a 2-3 year programme. So that's the first thing. The second thing is that's exactly what we raised with the minister. They've left it so long to give the money. Then in all honesty, Maria, that the fact that are we going to be able to recruit new staff by the end of March? Possibly not. Or if we are, we'll only just have them in March. So we probably won't see the benefit of them But we're really trying to push for a better plan around a 2-3 year workforce plan. And of course, it makes no sense in just doing a social care plan. It's got to be an NHS and social care workforce plan to be able to give some stability.
Yeah, and it's the opportunities that we can provide to our workforce will also rely on us working. We're talking to the local NHS and the I think also we must talk to our hospitals as well about the role they can play in that, because it's a big one. Natalia.
Thank you. I mean, I note that this is a yearly plan, but can we incorporate the impact as well of the cost of living in terms of workforce recruitment, retention? I'm thinking about some of the challenges as well that we're seeing right now with the cost of living crisis, especially as well in London, where we know that rent is so expensive, transport is so expensive, energy bills are very high. So is the cost of living crisis incorporated in this analysis, or will it be going forward in terms of future plans?
So for this submission, no, it hasn't. But as Lisa said, some of the reforms have been kicked into the long grass, but not all of the reforms have. So I think we've further work to do, both locally and at North West London level, around cost of living and the impact that is having. So locally, we've done quite a bit already. And as the council, we've a number of commitments to support key workers with housing. We need to do the work on London living wage, as Lisa says, and what does that really mean? So I think it's a longer term piece of work that we need to think about, but also think about how we're going to resource it.
Yeah, I mean, it's a good point, Natalia, that you make. I mean, we some of the things we've been doing, as a council for some time, have made things perhaps a little bit less challenging for people, although the energy costs swamp everything. But the fact that care is free, so in this borough you don't have to pay anything between £15 and £30 an hour for care, is helpful to about the 2,000 people in the borough that we help. Although probably there would be fewer than that, because some people simply wouldn't be taking the care they need because they couldn't afford it. The fact that we provide primary school breakfast for children, have been doing so for a long time now, again, will help some families. And there are other things that we do. The support we give with council tax for people who can't pay it, and lots of things. But you'll be seeing, those of you who live in the borough, which I think is most of you, many of you will be seeing dropping on your doorsteps quite very shortly a winter wellbeing booklet, which has a booklet within a booklet, which is all about cost of living and lots of ways of people, not just tips for saving money, but also quite practical things about how people can get benefits that they are entitled to, but they may not be getting, and about the warm activity hubs that we're opening around the borough, and lots of other things. But we will be coming back, I fear, to the cost of living for quite a long time. Okay, I'm going to assume from that we've had the discussion that we need to have, and I really appreciate all that everyone has said. It's really interesting, a rounded view of things, and that we're happy to note receipt of the grant, and look forward to many more. Note receipt, and we'll look at the measurement, take it forward. Thank you very much. So we're going to go to the second part of the meeting now, and I think we're doing quite well at the time, which is despite me rather than thanks to me, I have to say, intervening so much. And we're going to look at we've bandied around a lot of acronyms. It would not be a meeting involving councils and the NHS if there wasn't a vast amount of acronym use going on. So we talk a lot about the integrated care system. We talk about the borough-based partnerships. We talk about the local health and care partnerships. We talk about the integrated care board and the partnership. What we thought we could do is it's very, it's important to talk about processes. And probably the people in this room, or there are about 3 or 4 people watching online, nobody likes talking about processes, but it's important to talk about them because that's how things are done and decisions are made. But it's also important to talk about actual things we're doing once the right structures are in place. So we've tried to get a little bit of a balance here today, and we'd like to talk a bit together to explore that we're on the same page when it comes to what does the integrated care system mean and how are we involved, what's it trying to achieve. And I'm going to ask Rob to take us through that a little bit, and I'll chip in from the point of view of the council, because we're now one of the 3 councils who has been given a position as a partner member on the integrated care board. And then I'd like to talk, if we can, about what we're doing locally, about locally delivery and health campaigns. And Linda and Joe and others have been working and pulling together a series of presentations on what's happening, so we can do some short, sharp exploration of things that we're doing locally to try and help deliver the overall, well, to make things better for residents. So Rob, we've got in these slides here, Rob, I don't know if you've certainly seen these slides, because I think we got them from you, but we've put in the slides here. I don't know if you've got them to hand, or we've put them up on the screen, Bathsheba.
I can put them on the screen, Councillor.
Thank you. The schematic for how, and I warn you all, when this comes up on the screen, you will have a sudden urge to go make a cup of tea or something. But the schematic for how the integrated care system, partnership, board, and local authorities works. Joe, if you've got that, I would put up which is the slide that's at page. It's the second slide, the one after the summary slide.
Next one.
I can't see anything, but is that me? Hang on, let me just check. I've got two different screens open. Can everyone see something?
Yes.
Yeah.
Yes.
It's the next one, Joe.
Thank you.
Weirdly,
I think it's still loading. It's quite slow.
Can't see a thing. Let me see where
The screen you should have up is the Integrated Care Partnership membership. That's slide 3, colleagues. Councillor Coleman.
Yeah. That's good. It's not coming up on my screen, but that's because I can.
It's not quite there yet, Joe.
All right, I've
it's
got
not moving yet.
Oh, have you got the one which says resident engagement, Joe? Is that the one you're talking about?
Yes, that comes later, Councillor Coleman, as part of the same slide deck.
That's the one that's up.
Yeah, no, we've got the first page, Joe. It's the second page that Rob was just going to do an overview of the ICB and then the governance structure around the sort of the board with the changes, and then it's Lisa and I. Okie dokie. So if we go down to the second page, Joe.
I've got that on my screen, Councillor. The facts and figures, Rob Hurd, Chief Executive.
Has anyone else got it? I haven't, but no one else has got that. But you're very blessed. But we haven't got that.
No.
Joe, would you like me to try, Joe?
Yes, please. Yeah. I think my IT's failing me. Sorry, colleagues.
Right, here we are. Good. If you can make that as a full slide, that's yeah, that'd be brilliant. Okay, Rob, please.
Thank you, Councillor Coleman. So thank you for the opportunity to talk about and try and translate what the world of integrated care board. So clearly our origins were in the abolition of clinical commissioning groups, the new legislation, and we came into existence as a legal entity called NHS North West London, the Integrated Care Board, on the 1st of July. So the first thing, sort of just to acknowledge, is we are a new organisation. We are there were 8 CCGs in North West London, in each of the boroughs. They were brought together, and then this new illegal entity was created. And in legislation, I think one should never start a presentation of around health and care without rooting this in purpose for our residents and population of 2.1 million, but the fundamental 4 objectives that are set up in the statute as to what we are supposed to achieve to prove our worth and our existence over the next 5 years is a reduction in inequalities, improvement in population health and health and care outcomes, better value for money, and work with local authorities on wider determinants of health, because fundamentally we know we have a national hospital service, not necessarily a national health and care service in terms of how the NHS has organised itself. My background is in hospitals, so I'm repenting for my sins, because the answer is not to build bigger and bigger hospitals. It is to actually address the wider determinants of health, reduce demand on an overloaded health system. So we have exciting work that's taken place before I've arrived here around the 2.1 million population that's taking place in each of the boroughs, in partnership with the hospitals, with the voluntary sector, with mental health colleagues, with community health, with primary care colleagues, and something that brings together data across that 2.1 million people called the Whole System Information Centre, that tries to bring together the analytics behind need for that population, but importantly also a strand of work that needs to bring experience data, what we learned during the pandemic about the experience and lack of trust, frankly, in our health services of some of our residents, as we went through the vaccine program and started to get into inequalities of the experience, as well as inequalities of the population health, the access to health and care services, and the outcomes from health and care services. So that's why we have been set up to exist. And we have therefore what would traditionally be known as a commissioning budget, money that we are allocated from central taxpayer funds of the order of 4.5 million, which is then passed on to the various providers and other forms in the system to address those things. So there hasn't been a new magic formula applied to that. The way in which it is currently allocated is largely historical, and we have talked already on this call about examples of when new pots of money appear at the margin, that we have a role to be supporting the process for coordinating that in order to make sure we are addressing those four fundamental things around inequalities, population health, the health outcomes, value for money, and wider determinants. I think it's fair to say we are in the early stages of therefore having the new approach to what we are there to do to deliver on those fronts. And what we do is divided into three big ticket items. Number one is we are required to work with local authorities, the legal entities that are our 8 local authorities in North West London, and us as the NHS legal entity called NHS North West London, to agree a strategy for the that 2.1 million population. What is a strategy? A 5-year strategy needs to set out what our priorities are, the things we're trying to achieve for that population, but always rooted in localism, rooted in the needs of residents and communities, so that we are supposed to be adding value to the process by coordinating that across that in ways and supporting borough-based partnerships. And the importance of the borough-based partnership, for example, in Hammersmith and Fulham, as the Hammersmith and Fulham Health and Care Partnership, is kind of the fundamental unit around which we are going to develop and organise ourselves in each of the 8 boroughs. But around that, we are wrapping what we call our programmes, and we have a population health programme, we have a mental health, learning disabilities and autism programme, we have what we call our local care programme, which includes work around long-term conditions, end-of-life care, and we have work on our acutes, and many of you will know that our big acute hospitals have formed a collaborative and are working closely together with a view to learning from each other, sharing resources and sharing mutual aid and staffing. As we learned during the pandemic, that was a better deal for residents than competing amongst each other and ending up with what might work for an individual institution, but not the best result for a population against those objectives I've described. So can we move on to the next slide? So we're overall governed by a board, of which I am the chief executive. The statute requires us to have appointed a medical director, a finance director, a nurse director, and we have done that. And it also requires us to work in partnership through something called the Integrated Care Partnership with our local authority colleagues, which, as I say, is constituted of the 8 local authorities and is a joint committee of those 8 local authorities with NHS North West London. And that Integrated Care Partnership, the membership which is before you, is charged with essentially overseeing the agreement of an overall health and care strategy for the next 5 years. And we are navigating the landscape of our NHS planning timetables, but determined to put due time into co-production and working with borough-based partnerships against need. And Councillor Coleman kindly joined us on our recent meeting of the Integrated Care Partnership membership. And indeed, as Councillor Coleman has indicated, is also a partner member for local authorities of what's called the Integrated Care Board, which is the NHS statutory entity element of the Integrated Care Partnership. The agreement of strategy is sort of purpose number one, overseen by that, and obviously then needs to form plans and decisions and priorities that are made, such as those you've just been discussing around allocation of resources, around things like the NHS part in the Better Care Fund and the discharges funding and money that we have been allocated according to that. Do you want to move on to the next slide? Thank you. Well, I'll take these as information rather than read them out, but these are the membership of the Integrated Care. This is slightly wrong in the sense that the members that are described as non-executives are not members of the Integrated Care Partnership. They are members of the Integrated Care Board. So apologies for that list being incorrect on that page. So that the Integrated Care Partnership, Councillor Coleman, is the thing you were attended last week, which is the 8 local authorities and Penny, the chair of the Integrated Care Board. The Integrated Care Board, if we keep going, sorry, go back one. Sorry, I jumped over. So the list of, so for example, non-executives and partner members are members of the Integrated Care Board, which is the NHS element of the Integrated Care Partnership. So what the second sort of key purpose, so I mean, I'm happy to pause and take questions, but ultimately what we do as executives and as a board is work on that strategy, work on coordinating. For example, there was no convener and entity in the past pre-pandemic that necessarily convened all the organizations across the system to work on this sort of response to the pandemic and coordinating activities. So we have a coordinating, a convening role of health and care partners in dealing with operational issues. And we also have an assurance role in partnership with NHS England. And much of the tension arises where we are given rules from NHS England, which I think jar potentially with localism and how we would wish you would wish to be doing things within your borough. But we're the sort of stuck between the NHS England national approach to things and the localism of working with local authorities through borough-based partnerships. There are separate slides on a lot more detail, but shall I pause there, Councillor Coleman, or would you like me to say any more?
So I had to get to the microphone. No, that's helpful. That's a good start. Thank you very much. And I just, before I take a couple of questions, should we, well, you can let me know some. Do we have a slide on the slide deck that you're working through, which has how the different parts of the system interact with each other? Because that's in the papers which we sent out for the meeting.
Yeah, that's what I thought I was going to be looking at.
Yeah, sorry. So did I. I have to say, and I'm sorry about that. So what we could do is we could actually, while we take the questions, Bathsheba, would you go to the papers for the meeting, please, and put up the near the end of the papers this slide which is called schematic, which Rob, I thought that would, yeah, that's what I thought was coming up as well. So that's fine. We'll get there.
I did my best to do one presentation to the tune of another, but there we go. I'll hopefully...
Yeah, I know. So Bathsheba, you know what I'm thinking about.
I'm just trying to find it. If somebody can give me a page reference, that would be helpful. Thank you.
It's at the end of the document. It's on page 60.
Page 60.
Yeah, page 60. Yeah. And
can everyone see that?
It's good for me. I think you need to shrink it very slightly or we won't get to see the bottom of the page. Yeah, good. Okay. All right. I'm going to do that. Just put that up there. Just if I can so you've got the Integrated Care Partnership, which meeting at least, I'm just going to talk through it, Rob, if you don't mind. I mean, you can just, you're ready. But Integrated Care, as everyone can see on the left, Integrated Care Partnership meets at least 3 times a year. It's co-chaired by Penny Dash, from appointed by the NHS, and by Councillor Nafsika Butler-Thalassis, who is one of the 8 councils on the board. She's from Westminster Council. She's the Cabinet Member for Health and Social Care. And that meets to develop the overall strategy. It also has a massive, great forum where it invites over 100 people from all around the NHS and councils and other people 2 or 3 times a year to work on specific themes. But that's quite a big group. We can talk about that. Then you've got the board, which meets monthly to oversee funding and services. So the strategy is meant to set the partnership sets the strategy. The board is about overseeing funding and services and has to implement the strategy. And we can come on to the members of that in a minute. But the local authorities are, as Rob mentioned, members now, what they call partner members of the board. And we just to let you all know, we've taken the view that we've got 3 places now after some discussion. We have 3 places as local authorities, and we've taken the view that we should balance inner and outer and political There are 5 Labour, 3 Conservative councillors. So we have 1 Conservative councillor, 2 Labour, and we have Hillingdon, Brent, and Hammersmith and Fulham are the 3 councils on it. But we don't represent just ourselves. Obviously, we're here to talk about everything that's good for residents, and councils as obviously feed in and be able to speak for more than ourselves. And so we're on the board. We're also on the partnership, the councils, and then you have here we are. You have the joint health and wellbeing boards. Joint, I mean, just health and wellbeing boards, I guess. But yeah, which is us here today. So you know what that's about. Almost. And we do have a vice chair who's in the NHS, Vanessa Andre. So those I'll leave that slide up. Let's take some questions, a couple of comments, and I saw Meryl first.
My original question was but it's partly been resolved, was the fact that we'd had papers circulated and they weren't the ones that Rob was actually talking to. But I think it might be useful if the papers that Rob was talking to then were circulated, because there are actually names and job roles attached to those that I think are of use and interest to people. So
sure, we'll do that
later. I'm not sure how much detail to go on from that, how much detailed questioning one's asking for, but I noted that one is talking about, part of it is resident involvement. And I suppose my question is, what is the relationship, or what is the proposed relationship of the partnership with the public, with residents? Is that something that's going on up there, out there, that residents are not going to be engaged with or have any input to?
Okay, I'll give that to Rob first.
So thank you. So those of you who've listened to me over the recent months since I've started, is we've determined not to create a separate Northwest London engagement mechanism, that it is through the borough-based partnership and involvement mechanism that takes place, to value the expertise that local authorities have in their teams. So in terms of what we do centrally at ICB is to hopefully provide scale around communication and involvement resource that would not be able to be created in each individual. So it's supposed to be an enabler, facilitator of local resident engagement to inform that through the borough-based partnerships. Now, I am not sitting here saying that is, we've revolutionized the world of involvement, because the NHS has not been the best at this over the years. But I am here to say that we have an involvement strategy determined to work with local authority partners in terms of getting that insight from local communities and local residents into our plans. And it's why I'm nervous about any agreement of strategy and any sort of timetable that's this year that's anything other than the beginning of a journey around priorities. While we have to sort of keep the show on the road, the phrase, we're building the plane whilst it's in flight. We have to sort of coordinate things operationally, but in agreeing a strategy, that involvement function through the local authorities and the borough-based partnerships is where it's meant to be. Now, occasionally London and our national masters do other initiatives that we try and keep an eye out for, and we try and align those with local forums and local processes, rather than setting up separate things. But that doesn't mean we always succeed in doing that. But the intention of what we're trying to do is do that with local authority partners at a local level.
Good. Okay, I hope that's Meryl. I'm going to bring some other questions in and then come back to you if there are still things you want to clarify. I've got Luxan next.
Yeah, thank you, sir. So from our perspective, I believe sometimes an area can come under varying trusts, and from experience, the A&Es often used to sit under a different trust. So the stance towards ICB, does it incorporate the whole of the NHS framework into a clearly sort of structured and accountable system? Because some of the issues that we see are that you have local care providers with the NHS, and there's often a difference in view, or sometimes we're not able to seek the sort of relevant accountability for, say, an issue such as mental health care, because it can sit within very, very different departments. So I thought I think we initially had the the clinical care group, and then that was reformed to the ICB. Has that taken that learning on board and sort of made it more streamlined? I know that we had the safeguarding minister over at Charing Cross a few days ago. And that's one of the things that was raised around that. And then secondly, around the stance towards the ICB. Do the NHS now have a single form of data sharing system where, I know that information sharing can sound scary to the public, but information sharing is, vital. Having that sort of easy accessibility to the information can often be, it can save a lot of lives. We can access relevant information such as medical records, etc. Has the ICB taken that into account? Because we also find that obtaining data is very, very difficult from the NHS, especially within partnership meetings as well, from experience.
Rob, I see you nodding away there.
Well, thank you. I mean, I think in the first part of your question, you've highlighted kind of one of the reasons for our existence, in that we're trying to balance what is the right scale, and I hesitate to use standardization of approach, the core offering for residents that's not inequitably provided depending on what borough you live in and how you interface with the NHS. Now, we have to balance that with the localism and the need for local responsiveness and variation, and all our communities have differing needs. But one of the core principles here is that by scaling that up to a body, NHS North West London, we have an ability, through the programs that I've described, to ensure, for example, our acute hospitals, our A&E departments that you described are acting in sort of the collective interest, as opposed to necessarily fighting amongst themselves or doing different models, care models, etc. And we're on a journey in that we're going from where we were to where we need to get to, and the balance we need to strike is what are the core offerings that everybody should expect from the health and care service, what are the local variations of that which are inevitably going to be necessary to be responsive to the local needs of communities. So the answer to your question is that is why we should now have one written. I talked about our program. So, and in A&E departments, our acute program brings together the 4 trusts and their A&E departments that have A&E emergency departments in, and looks at those as one and compares and looks at what the differentials are. So that and therefore we as a overall NHS have more clout, if you like, than each individual borough to influence some of those things. But we need to strike that balance, as I say. On data, yes, so we have, I think we may be unique in the country in that we've cleared the information governance and information commissioners sort of regulations around getting consent on primary care data being shared with from each of our general practitioners, all bar 2 across the whole of North West London. And if I talked earlier about the whole system information system. So that is what we call our population health management database. It brings together, allows us to ask questions about need, about the different outcomes that we're achieving for our population. It's anonymized in terms of asking those questions. It provides the input into our understanding in sort of data terms of the needs of our population, which has to be married up with, as I described earlier, the reality of the experience and what patients and residents are seeing. So it's one part of, but not the whole part of the story about understanding need and gaps in care that we have at the moment. The other part of data is what we use to, what you're probably alluding to is that, can we have sort of a common care record, and that we have all parts of the system have access to a common care record. And we're about 2 years away from that. So in terms of each of our hospitals, mental health, community health, primary care providers, all being able to look in one place and see the same record across all aspects of those things. At the moment, it can be brought together into one place, but we have not got all the sort of systems aligned. But that is a work program to ensure that we have joined up care records so that residents can, through the NHS app and other mechanisms, see, one version of that is held by all the different organisations. So that does come together currently, but we're working on far more seamless, better ways of that being available. Again, as you allude to, we have to tread sensitively with people's rights around access to data and who can view that data, and the clinicians that need to, and the individuals that need to. But that's a different thing to the thing that I described earlier, which is where we do share anonymized, used for research paper, used for need basis, where we can't link that to individual patients' information.
Good. Okay, looks, I hope that's reassuring. Yeah. I'm going to bring Jim to the question. Thank you, Rob. Jim.
Thanks. Robbie, you actually cleared up one question I was going to ask, but it led to really my second one, which was this, in that you're quite clear about the scope of the board, about North West London in general, but there are multiple references to borough-based partnership. So in the recent past, if somebody wanted to know, they would know that locally the CCG was the calling point, and they knew that the CCG locally was part of a wider whole. Borough-based partnership is not a phrase which resonates beyond those of us on screen and like people. So there's a question there about visibility of borough-based partnership, like what's its calling card? How does one get in touch with it? Is there a kind of a membership envisaged?
Going to talk about the borough-based partnerships in just a tick, so I'm going to hold that question, Jim. Yep, that's okay. Meryl, you want? No, it's a good question. But we're going to talk about them. So we're just being super top level at the moment. Meryl, did you want to come back on ICS?
I do. I want to come back on the partnership board, because at least on the slide that's now on screen, it talks about the partnership board having a responsibility to develop overall strategy.
The partnership, it's weirdly, it's not called, it's this.
No, sorry, not the partnership.
This is just
the integrated care partnership.
Partnership, and then there's a forum, and then there's a committee, and there's
but the partnership is the one that is labelled on this as having the overall develop the responsibility to develop the overall strategy, and I think Rob's answer seemed to push public involvement back to local borough-based partnerships. Now, I accept we're going to discuss that later, but I don't think he really answered the question about, because strategy will relate to development of policy, of an overview of things and how we get there. Are residents not going to be involved in that? Because looking at it just from local authority level, borough-based partnership level, is going to fragment that process and not allow residents across Northwest London to engage across Northwest London in those issues.
Okay, Rob.
Okay, so I think you make a very important point, Meryl, that essentially we've got to get the balance between, I hate to use this phrase, but building this from the residents up to the bureaucracy down, and we have to get the balance right there. The integrated care partnership, I would just, it's not going to do the meat in the sandwich work of the strategy development. It is overseeing, and it will sign off essentially the strategy. Now the plans that then flow out of that, which, as you say, need to be informed by, so it needs to start with need, and it needs to then flow into the prioritization process that we have for the population, so that we can then have an overall guiding strategy that is a framework within which the borough-based partnerships, which we're about to talk about, operate. It has not been determined, because we've got to still do the work together, the extent to which we have, there's going to be principles in there like delegate except where it doesn't make sense to do so, where there are cross Northwest London issues that are so important in terms of needing how we're going to organise programme and agree to a cross borough approach, cross population approach, that will all be brought to bear. And that will then inform things like financial strategies and plans, things like how things are allocated, etc. But that comes at the end of it, and the policy, the form needs to follow function. We need to agree what we're doing, what we're setting out to do together in overall terms, have a strategy, turn those into plans, and then agree. And all I am fearful of, what I'm fearful of, is creating too much of that at a centralized level, wanting to support the borough-based part, which we're about to talk about, in being the key unit around which that is developed, but acknowledging that there are as has been alluded to already, some significant variations, therefore, that are unacceptable in terms of health and care services. What I'm describing as core standards. So what the North West London level will do is ensure that those core equitable standards are being commissioned, provide variation to local borough partnerships in terms of anything around that. We will organise things across North West London, which are better to organise across North West London for borough-based partnerships to succeed. And one example of that is digital, I think, where we've tried and failed for many years, have we not, as a health service, to bring together digital and develop data and how we can do that. So the unit of strategy around data, that 2.1 million population, there is more to be gained from each borough in participating in that, is my belief, than if we fragment that to each individual borough or subunit. That doesn't mean integrating. Okay. We're trying to develop things. So that's just an example of trying to balance what's the right thing at the right place that we will establish as we go through this journey.
So that's really helpful, and we talked in the meeting that we had recently of the partnership about the strategy and the nature of what we're looking for. I think we're producing a very, I can't remember the frame that was used in the meeting, but very much an outline strategy is what we're going to be doing by. It's not by Christmas, is it? It's going to be by.
Well, we'll have a draft we'll bring together for programs in January, but that's really there to start talking about. And remember, this is being formulated from also taking on board all the work that's going on in health and wellbeing boards in terms of local community and resident events. I mean, I've attended some of them myself. This is not a separate thing that's being done. It's being built up from that exists.
That's right. And taking that, we're going to the just to give a bit of clarity, I guess, about how the strategy, because there is a lot of work that I hear from residents and things we hear from residents that I will be feeding into. All the 8 councils are on the partnership, and I hope that other councils, well, it's up to them how they operate with their residents, but they may wish to do the same. But Rob, what did we just for people who I haven't fed back to yet, to be in any great detail, it's a good opportunity to do that. What is the NHS is requiring certain things of all the ICSs in terms of developing a strategy. It might be just worth reminding people what that is.
So I mean, to be honest, it's very, very loosely defined at this stage. The bit that we have to watch is that what we call the NHS planning round and planning guidance is not the same thing as what we call the strategy. We will have to go through a traditional NHS planning round, and they will ask us to refer to our work on the strategy. But essentially, it needs to, a strategy identifies need, starts to work through what our priorities might be, what measurable things we might be seeking to achieve over a 5-year time horizon in terms of benefit, whether it's in hypertension, whether it's in inequalities, in cardiovascular services, diabetes, key population health issues and prevention issues. I mean, I don't want to start writing the strategy now because I'm just giving you some examples, but those are the types of things that we will need to create a plan for. What is required in general? I mean, I'm very, very keen. This is only draft early stuff that we bring together from existing information that then informs future prioritization work. And remember, then when we are doing any big service change, any consultations, engagements with residents and community, it will refer to the strategy. It will refer to the sort of tests that the system has to go through before those changes can be enacted and agreed locally, because we will have a statutory duty to consultation and involvement on the NHS side in terms of any NHS service changes. So the bit that's going to be created is a draft, relatively high level, building on existing information, having engaged with the programs of work and the engagement mechanisms that we've got so far with the health and well-being boards and the local work that's been brought together. It will then evolve and develop, I think, into tackling some, because if we'd have tackled them before, we probably wouldn't be setting out to change the way in which we're approaching this. So it will then evolve into how we turning those into plans and the actual sort of operating model, if you like, of implementing them.
Good. Thank you for that. I'm going to move on to this is only the first. We're going to be talking a lot about this over the months and years to come. I'm going to move on to the borough-based partnerships, Rob. Thank you for setting that out really helpfully and taking some initial questions. I know if we could, there are lots and lots of questions, but that's starting to give a flavour and trying to get people make the whole thing less freaky, I think it's supposed to go. And Jim, I'm not going to bring a question in now. I'm going to talk about the borough-based partnerships first, if that's okay, simply because of the time. I'd like to move on. The next slide that I've seen from the official slide says I'm going to talk about the relationship with councils and stuff. I'm just saying with councils are sitting on the board, sitting on the integrated care partnership. You will take a view on whether or not we are engaging Meryl and Jim and other residents sufficiently with you that you feel that residents are being involved in that way. But which doesn't answer the full question. But let's talk about the boards. Well, we don't call it the borough-based partnership, do we now? We finally decided to health and care partnership.
Health and care partnership.
Yes, because there weren't enough new names to learn and different terms. So we
well, you know.
So it's borough-based partnership, BBP, aka HCP.
Yeah. It's snappy, isn't it? Snappy. So if I make a start and and I'm aware of time, Ben and everyone, so I'll speed read this. So our health and care partnership is going to be officially launched later on in January, and there's a number of people who are either on the executive, which I sit on, or on the wider ICP, on the health and care partnership group. Go
down one, Bathsheba.
Yeah, that's it. Thank you. And then I think you're right. And just to pick up on, I think what Meryl said, or Jim, probably does feel hard to get hold of from the outside. And Rob's just talked about the ICB, as has Ben. It probably does feel, a little bit hard from the outside to get hold of. So I think that's why it'll be good in a moment to talk a bit about the resident perspective, and Trish and Maria, who are on the local health and care partnership, to talk a little bit about how they feel, how they view it's making a difference. But I do take the point that it is hard to get hold of. So we have an executive, and that meets fortnightly, and then we have the wider health and care partnership group, which involves many people, as I say, many on tonight's virtual table, and GPs, other senior clinicians. Also, we meet fortnightly, and then we have a wider board every quarter that was set up pre ICB land. Main focus is driving through the strategy, the policy, and the operation. And we have been meeting now for about a year and a half. So I think we're beyond the in the norming and forming. I think we're a very good tight unit, really strong relationship, and I think that's our strong. I think that's our real MO. That coming out of COVID, we'd already built, and I think we've talked about this at Health and Wellbeing and at our packs before. I think that's really bodes well for the future, that with those strong relationships, we can tackle some of the challenges and the difficulties that do face us, whether that's about local operations. And I think that's really important. It's a shame Philippa can't be here tonight. I know she's unwell. She chairs the exec. We have 4 campaigns. That's population health, diabetes, frailty, and mental health. And again, we've got leads. We've got leads around the table tonight who are involved in that, and we're going to talk about some of their work as well after that. I think in terms of benefits and outcomes, we're working hard to look at how we're making a difference, how we can demonstrate how we're making a difference as a group, and as a wider group as well. And I think that's in terms of process, Sue, that's kind of process and governance. That's all I wanted to say. And I know Maria and Trish are going to come in, so it'd be good to hear what they have to say and their perspective of it.
So thank you very much, Liz. That's really helpful. So what we're going to do is I think we're probably going to run over to a bit past 8 o'clock. I think we'll try and 10 past, quarter past, but I'm going to try and be tight with it. And it's just whilst people say a couple of words, maybe if there's a lot of words in the slide, they don't need to say them all. People can, and we can take some questions as we go through on each of those. But we're going to have an insight into the work that you're doing in a series of areas. So, Trish, if you go on to the next slide, please, Bathsheba. And Maria and Trish, it'd be great to
so this
over to you.
Thank you. It's great to have this opportunity, and the discussion is brilliant. So Maria and I are part of the partnership, and what we wanted to tell you is that we're not doing it perfectly, but there is a really strong commitment to co-design and co-production. We know that the borough cares about it. We hugely care about it, and I think it's really important that the snappily titled Health and Care Partnership is also very committed to it. So we're doing our best to co-design and co-produce what we're doing locally, and that's very exciting. We've got a number of processes here, and I'm afraid I'm not very good on processes, and I'm not terribly impressed by process necessarily. I know we've got some great campaigns. I think that what Maria and I wanted to tell you is that we believe our involvement and all the other involvement where co-design has taken place has made a difference. That actually integrated care, which is what we're talking about, connected care, is critical for us as residents, because we know that care breaks down at the transitions between the GP and the hospital. It breaks between the social care and health care, that there is no shared patient-owned record, and that's really important, that it's not just a shared record, it's a patient-owned record, so that we know what's in it too. That the measurement, and you've talked about measurement, that the measurement is usually about how many you do of whatever it is. It's not about whether actually what we achieved was what the resident, the patient, the carer wanted to happen and how satisfied they were with the service. There are some bits that are very much about the North West London level that Rob's spoken about. We cannot have an integrated system until we have an integrated appointment system. Any of you who've tried to have an appointment in the NHS will know how awful it is, but actually no single trust, no single anything can do it on. We need to do that as a system. And I think that's a real challenge for North West London. So that's certainly something at the strategic level, it would be brilliant to have. You know, as would the patient-owned record, you've said at the end of next year, probably, Rob, and I think that's fair, but we need to be planning for it now. How are we going to do that? But there are things we've done locally. So we've got, and Ben, you'll recognise this, we've just restarted our patient reference group, and Meryl and Jim are there. And we are there saying what matters to our residents. What is it about the care and treatment, the problems you have locally? And we're on only our second meeting. But actually, what came up was referrals as the most important. So we got Imperial and we got GPs, and then they listened to what residents said about what was going wrong about referrals. All those things, information getting lost, not knowing what's going on, people using language you don't understand, huge waits and not knowing what's going on. No waiting well, it's waiting and getting increasingly anxious. So we have now developed an action plan around that, and we're going to keep on looking at that. So in a way, Ben, I think what Maria and I want to say is that we believe we are at the start of something where we are working. We trust the local authority is part of our patient reference group. You know, it's not some, you know, we do things much more together. There is much more trust. Maria and I feel we're listened to. And that actually, when we say all those awkward things about, yes, but where's the patient in this, and how about that, and how about the other, people actually listen and care and work with us. So I think we've got some rather fertile ground to work on. We've got loads more to do, but for us, I think it does feel positive, as for the first time we are doing a bit of co-design across all our stakeholders, and that feels really great. Maria, do you want to say anything? You're smiling, I know. We planned this.
I know, I couldn't put it better myself, Trish. I'm laughing, actually. I'm the North West London Integrated Care Partnership local lay representative. Now, I didn't know that. I have to say, we've been through so many iterations of integrated care. And in many ways, I think this has been the best. And I think it really is because, and I, at the risk of sounding cringy, it's great having local authority, health, voluntary sector. I think I've learned over the last 6 or 7 years since being involved in this, that you never really know how life really is until you involve the right people. And I think where we are now, I think you're right, we've taken a long time establishing relationships. I think There's been a lot of operational stuff that needed to be done, and rightly so. But I think what we hope to do is to learn from COVID and how people work together and got things done. I'm a bit like Trish. I'm not very good at process. I'm not very good at busy slides. So everyone knows that. I'm very good at being the grit in the oyster. But I genuinely do believe that we're in a position now where we can start building on things. And I think what my ask would be from the local authority, from Shad, Sue, Sharon, the reach that you have. I've sat here and as I'm going through, I'm thinking virtual wards. Oh my goodness, what about the energy use? It just brings in a different perspective. So I think the PRG's the best achievement we've made in getting it resurrected, so to speak, because I think we lost somewhere where, in fairness, we could challenge the strategy, Rob. So it's kind of influencing and challenging. So I hope there are more of me and Trish out there, because there are Meryl and Jim. We've got some brilliant people, but we need to get some more voices across the board, and also intergenerational things. I think we just need to think very differently and help to use some of this money that we don't know anything about as members of the public. I would be saying, can we not get into schools and start trying to say to people, caring is valuable. Let's start a new workforce and do some things in parallel. So
thank you very much. No, that's really, really helpful. I'm just going to bring Jackie, before I do, and Marie, that's brilliant, and it's a good challenge, and it's also it's encouraging. And Sarah writes, agree, youth voice, which is good. In the chat, can I just say, I give a slight. I didn't realize there were two screens on this. There were two screens on my screen, as it were. New people have joined us, so I should have welcomed Carleen from Health Watch and Angela from Children and Young People in the NHS. As well as Councillors Alexander Sanderson, who's the Cabinet Member for Children and Young People and Education, and Councillor Helen Rowbottom, who chairs the relevant pack. So it's good to have you all here as well. Have I missed anybody new who's joined us off? I don't think I have. Forgive me if I have. It's lovely to have you here with us. And I'm going to bring in Jackie McShannon, our Director of Children's Services.
Yeah, thank you very much. And other people may be able to answer this question, but really exciting work, Maria and Trish, that you're doing. I wanted to ask about representatives of children who've been patients, and how you're liaising with them and how they're represented in the residents' engagement, children themselves, but also with lived experience as patients, but also their parents and carers.
Do you want me to come in on that?
I was going to say, personally, Jackie, I don't think we are, but that's because of where we are as much as anything. So I think Sue will probably be able to tell you more about it. But certainly we've had representation. I know Nikki's always filling us in. We've had more things to prompt us to go there, I think. And I'm a paediatric nurse, so my heart's always there anyway.
Thank you. Sue, did you want to?
So Jackie, I mean, it's through your groups that you sort of obviously work with all the time. So we don't have children and young people represented on the patient reference group, but that is not that they're not able to come. But obviously we work with your teams, with Sarah, with Alison, to sort of look at how sort of Parents Active and other groups that you would sort of already liaise with. Sort of through those routes. But as you know, Jackie, we are sort of still looking at having sort of specific things around children, so that we can then engage directly with children and young people on those things.
Yeah, I think
so if I may come back, Councillor Mayor.
Please.
So my concern has always been that in some ways our reach is limited, and that we won't know every child and family who's been a patient or a lived experience of health, and I suppose I'm putting some challenge into the system to think beyond the reach of a director of children's services, so to speak, and absolutely going into schools, as has been flagged up earlier. That's where we might get that greater reach. But I suppose I'm asking the system just to think a bit broadly about children's.
That's very helpful.
So I would totally agree. And obviously, Jackie, you are a member of the board, and we jointly chair our partnership board for children. So actually, we've got a real opportunity to do that. So that there's nothing stopping us from sort of moving that forward.
I'm going to be, that's helpful. It's a good point. we need to explore more direct representation of young people in creating services. So I think we just note that. That's what I'd like to do, because I'm aware of the time, and I'm sorry about this. I'm going to make a suggestion, because I've got hands up, but some of the slides you will see address many of the same things about involvement. So what I'd like to do is I'd like to go through the other presentations, which are going to ask to be up to about 3 minutes each, and then come back for a round of questions, which I hope will encompass. You'll see there's a Venn diagram, things overlap a little bit. So Joe, if you're happy with that, and if not, I'm going to go straight to Joe, talk about dementia, and with Peggy. Next slide, I think, Bathsheba, if you would be kind enough, please. Yeah, okay. And there are 2 slides on this.
So,
no, 1 slide on this, sorry, 1 slide, yeah.
Sorry, Councillor, just to let Joe know, Helen's just joined the call now.
Excellent. Thank you, Bathsheba. We were just waiting for
Helen,
our colleague to join us. Thank you, Councillor Coleman. Okay, colleagues, we'll be brief then. Peggy and I just wanted to update you on resident engagement in relation to dementia. So, as you all, I hope know, our co-produced dementia strategy, we're now in year 1, the back end of year 1 of implementation, and co-production with residents remains core to the work. We've had 2 significant pieces of work that I just wanted to say something briefly about. One was a workshop that we held in Shortlands with residents with dementia and their carers, which was an eye-opener and hugely helpful in looking at how, as an integrated system, we can improve services and support and really get some case studies and some stories from our residents. And the second, as I said to Councillor Coleman, I think to really engage with residents, and Maria last week, to really engage with residents, our view is that you've got to go, A, where they already are and where they already feel that they're in a trusted and a safe environment, and ideally a warm environment as well. But also there has to be an element of fun. Because I think really, you know, the starting point for a good conversation is ideally something where residents feel calm and relaxed, and where they're not being asked to do something on our terms, but rather where they have some choice and control as to why they're there. So the dementia fair that some of you were involved with, many of you were involved with, was a huge success in that regard. It enabled us to build up contacts with new residents with whom we hadn't had a relationship with before, and we hope to capacity build those residents in the same way that our Disabled People's Commission has continued to capacity build a new family of co-producers as our new dementia co-producers. And then the last thing that I would say, builds on what Maria and Trish and others have said, is that we're conscious within the world of older residents and across the integrated care partnership, the borough-based partnership, that we've got a whole proliferation of engagement, co-production, some of it part-baked, some of it well on its journey. But we need to bring it together because none of us are awash with resource, and it is resource intensive. And so going forward, Christopher Nicklin, my colleague who leads on the main body of older residents that we support, will lead a group where we bring together the professionals across the partnership and look at what events and opportunities we have together to build on co-production, build on relationships with residents, be it through the work of the warm hubs, be it through our health and wellbeing activities, be it through Dementia Action Week, which Peggy's already planning for in May next year, so that we have a little bit of a celebration of our integrated work rather than continue, as we tend to do at times, to do things in silos and fall back on old ways of working. I'm going to hand over to Peggy now, Councillor Coleman, because Peggy has just a few updates on some of the tangibles that we're delivering.
Great, thank you.
So very quickly, I'm Peggy without video. I'm sorry about that. From the point of view of the resident engagement, again, we're talking about, let's be broad and say people over 50, but in general, we're talking about the older residents of Hammersmith and Fulham. So in the strategy and in our implementation plan, we are cooking up an involvement with a couple of the local charities that are working with older residents, Nubian Life and for Brian. And the focus of these co-production let's call it a roadshow for lack of a better word, is really trying to focus on those in the community where they have less trust. So we want to make sure that we understand the barriers, for example, about why people are not coming forward for information about whether their condition should be referred to the memory clinic. We have a very low dementia diagnosis rate in Hammersmith and Fulham, and we need to unpick why that is the case. And further to that, and kind of building around it all, is more co-production with a roadmap. We lack information. Our residents have told us that. So we're using an existing platform and reaching out to local residents to help get something that's tailored to their needs. Then we're developing, and I'll stop with this one here, the idea of train the trainer. Now this is pretty radical. The trainer is going to be a person with dementia. It's going to be a person who's recently diagnosed. It's going to be a person who's in earlier stages of dementia, possibly a younger person. But the idea, building again on the disability mood, is that we train a core of people that see a real purpose and a real way to contribute to the community, even though they have a diagnosis of dementia, to be able to help engage future generations of people that are diagnosed with dementia, bringing together Care Network, the work of the Memory Clinic, a lot of our, climate group, food group, everything. So, and finally, I guess, maybe Joe, you should just mention about the Dementia Hub.
Yes, very briefly, Councillor Coleman, I know we're short for time, but Dementia Hub is something that we're working on together with colleagues across the council, across the NHS, and we're looking at how we can better meet the needs of our residents across the borough, providing culturally sensitive and local services in their area that bring together the work of the integrated care partnership, so that it's not a social care response or a health response. It's a voluntary and community sector, health, leisure, a very holistic piece across the authority. And it'll be something that will be our centrepiece for our manifesto commitment to become a dementia-friendly community.
Great. Well, thank you very much. And I feel bad asking people to save questions to the end, because each of these presentations throws up specific issues as well as general ones, but I'm going to have to do that. Just to clarify, the next presentation was going to be on palliative care, but Philip is not here.
Yeah, so I was going to just quickly.
Okay, we've got 2 slides, so I'm going to ask you to act as if it was only one small slide.
Don't worry, I can be brief. So, this, I think the Health and Wellbeing Board will probably be cited on this anyway. So there is a North West London programme around engagement for end-of-life and palliative care services. And as people will be aware already, we've made a strong commitment around co-production. And I think this is one of the things that we've worked really well on. And Jim and Meryl actually spent a lot of time with one of my team sort of co-designing and co-producing how we would undertake this piece of engagement, and it has been successful to date. There is still lots of work to do, and I suspect we will need to go back round the loop in the new year with some further engagement, but it was really good piece in the understanding of how we were going to do something differently, how we were going to approach our communities to get feedback, and then actually taking that work forward through the Health and Care Partnership and through the Palliative Care Group. I'll leave it there. I'm sure Jim and Meryl may want to come in on it, but I'm conscious of time.
No, and it's a big, I have to say, looking as an outside observer, it's a big step forward from the way we were engaging on palliative care before. And I think there was a big explosion in us and Kensington and Chelsea and Westminster and things. And I think the NHS really took that on board and took a few steps backward and come forward in a very different way, which is really welcome. So thank you for that. Though we still wait to see the outcome. Brilliant. So if we go down 2 more to slide number, 2 more down, Rashid, if you would, to the resident engagement, the mental health campaign. Yeah, that's it. Thank you.
Hi there, I'm Helen Mangan, Deputy Director at West London Trust. We haven't got many words on a page because we've got a group of us here to speak about what's going on. So I will invite colleagues to speak in a minute. Just to say that the mental health work stream has been running for about 18 months, and this covers adults and children. So we have a small group here tonight just representing social care, health and the voluntary sector, particularly Sobus and Rethink, which is demonstrating our partnership approach to resident engagement, which is very much work in progress. I wanted to emphasise a couple of points at this stage. It is work in progress. There's lots more to do and lots more we're about to do. It's not cost neutral. So we've had to organise our budgets to make sure that there is funding in place. And really, really importantly, and coming from West London, you may appreciate why I'm saying it, it's Hammersmith and Fulham specific. So there's some of the ingredients that we're really keen on focusing on. I wanted to say a couple of words about the mental health stakeholder group, which has been running alongside the work stream. This is a monthly group and it is attended by about between 20 and 40 people each time. It comprises voluntary sector colleagues, service user representatives and statutory services. Now, this started off as a place to share information about services because different agencies didn't know what resources were available. But it's now very much about relationship building, making connections, raising issues, particularly as we're bringing new organisations into the frame in Hammersmith and Fulham. So it's very much part of the system. So I just wanted to say a little thing about that, but now I really want to invite colleagues in children's services. So I think Helen Green's here to talk about the co-production work in children's services, along with Angela Calder and colleagues from Rethink. I wonder if you could say a couple of words about what's going on in children's and then something from our adults colleagues.
Yes.
So shall I?
Helen, do you want to go first?
Helen, go for it.
Yeah, okay. Yeah, so Helen Green here. And I was going to talk about the sort of Youth Voice Network and the Youth Council, and particularly highlighting, it's a priority for the Youth Council and for young people. During 2021, Healthwatch, Hammersmith and Fulham wanted to find out more about how young people felt during the pandemic. And this was quite a creative piece of work with young people who they worked in co-production with the Youth Council, and they carried out additional deep dive research project, including focus groups with over 300 young people. And they produced a video that I think a lot of people have seen, made up of clips from mobile phone footage, expressing their feelings about how they had got on during the pandemic. Following on from that, there's quite a summary of recommendations, again, sort of the ways in which they'd like to be involved and how both the information that they receive, they want sort of peer support activities and experiences, and they want school involvement, involving students in school mental health policies and how internal school support might help. So again, it's very much about their experiences and what impacts on their lives. And we work in partnership with Angela and colleagues and Rethink. Again, often they come and present at Youth Council and then it goes out to our networks. Are you going to come in there, Angela?
Yeah, sure. Thank you, Councillor, and everybody for inviting us. We have a range of mental health co-production activities for children and young people. And one of the reasons that we in the local ICB Borough Children's team commissioned Rethink is to make sure that we were aware of everything that was going on. We know that the Trust are doing things, our mental health in schools teams are, and we've got all the council activities too, as well as other voluntary sectors. So the first thing we're doing is really a mapping to make sure that we understand all the co-production activities, that we're not duplicating, that we're using very scarce resources in the best possible way across the patch of Hammersmith and Fulham. And Also, we have our 16 to 25 work stream, where we've done quite a lot of consultation with both North West London young people, but also Hammersmith and Fulham young people, in finding out what the gaps in our transitions work, what 16 to 25-year-olds really need for their mental health to recover and to actually thrive. So Rethink are linked into all of that. Once the mapping is done, they're also working very hard on recruiting our young champions. So we'll have Hammersmith and Fulham young champions that will be able to co-chair our emotional wellbeing partnership board and be part of our Hammersmith and Fulham mental health campaign as well. But if I could just pass over now to Carla, just to say a little bit more about the young champions. Carla,
I'm not sure we're going to have a lot of, forgive you, because I know a lot of people have come to the meeting today, but I don't think we're going to have a lot of time to take much more at this stage. I'm really sorry, and I apologise to people who are coming on to say things. I really am sorry, but I do think we probably need to, because I'd like to get people a chance to chat, and I think we're going to run out of that time. But it's very interesting that what we're hearing, and I think probably we could devote more time to it. And my colleague Helen Rowbottom's already got some ideas. I know what she'd like to talk about at the end. She's been not sending me messages. I'm going to go on. Thank you very much for that. I'm going to go on to the final.
Councillor Coleman, could we just have a word from our adult colleagues, Michelle and Shad, around some of the voluntary sector work they've been doing? I wonder if they could say 2 minutes on what they've been doing. Thanks for that.
2 minutes, right? It's gone down from 3 to 2. So I just wanted to talk about a programme sitting under the mental health campaign, and that's the mental health community grant. So I see this as a truly collaborative approach between West London Trust, the council, and SOBUS. Funding's come from NHS England to develop a new community offer that supports enables good mental health and wellbeing for our diverse Hammersmith and Fulham population. We identified 5 priority areas in consultation with third sector organisations. These were English not being a first language, and those who've experienced trauma through migration, the BAME community, LGBTQ+ community, learning disabilities, physical disabilities, neurodiverse disabilities, and young people. So this is primarily, we see this as a preventative approach, an asset-based community development approach. A lot of the organisations that we've funded are grassroots organisations where the staff are local residents, committees are local residents, and volunteers are local residents as well. So as well as being a preventative approach, it's also enabling underserved communities to start to trust and use mental health services in the borough, and also to enable our statutory mental health services to link people into communities of interest so that people don't feel so alone, can make friends and have fun. And I think it's been a joy to work with some of these providers, with all of these providers, not some of them. So for 22-23, we had £200,000. We funded 11 projects. So this was just for adults, and we had £30,000 for young people's project, and we funded 3. So then on average, they're not getting much money. The adults is about 18,000, young people's between 9 and 10,000. It's a wide range of offers, from massage for the Iranian community, dance and yoga for people with learning disabilities, art groups and trips out for BAME women, photography for older people and for younger people. And then we're also funding some programs where it's about intensive work with a small group of people. So for example, young people at risk in terms of gangs and county lines. So just in summary, the funding was for a year, but we've extended it to the 31st of October next year, just to explore a new model of delivery and learn from good practice around the country. Yeah, some amazing stories of residents supporting crises, learning different ways and techniques to support themselves and their families in terms of mental well-being, people enjoying life, and of a complete and absolute commitment.
Sounds good.
Staff
Sounds
and
great,
volunteers.
Michelle.
Yeah.
Well, thank you very much.
No problem.
There's a lot of amazing work happening and people coming together, and I think you're all showing that. And in a sense, having to curtail you in the middle of being passionate is it conveys all the things you're doing. I know you hadn't. But saying, as I said, having to curtail you in the middle of being passionate is I'm afraid that's there's one way. There are two ways of becoming popular as a chair, and sometimes stopping people speaking is as good a way of becoming either popular or unpopular. But I'm going to need to move it on, Michelle. You're doing wonderful stuff. Thank you very much. I'm going to take the last presentation, which is Sharon. You're going to talk about what we're doing to build trust among Black and minority ethnic communities. Sharon Tomlin, who's a community activist and organizer.
Yes. Hello. First of all, can you hear me?
Yes.
Yep. I'll just go straight into it simply because of time is of the essence. We have been working across the sector with stakeholders from across the sector. That's the local authority, and this work, by the way, has been triggered by the local authority. Thank you very much. As well as the health sectors, the voluntary community sectors around building trust within the Black, Asian, and multi-ethnic communities. We have come together as a steering group, and we've been meeting regularly for about a year. And my apologies for not being on camera because there's something wrong with my camera now.
Don't worry.
So in part of the decision around about looking at exploring how people from the minoritized communities feel about their interaction with health systems. We've come up with the idea of initially introducing this conversation by organizing listening workshops. So we've been successful in securing a couple of organizations, Apricot Wellbeing and community organizers, who will help in terms of facilitating that dialogue. What does that dialogue look like? Well, it's from the community organizing perspective, the community organizers, it's a dialogue process that will help the residents to surface the issues. And it's about encouraging participation. And it's a process of offering opportunities for people to influence the decision makers in the long term. It's more about sharing power, by unpeeling and unpicking all issues around that has been brought up in particular, and my apologies for going around the houses, brought up as a result of this conversation actually was brought up as a result of pandemic. Pandemic highlighted how little people knew about inequalities and how it affects minoritized communities. I was going to reference a story about my son's friend, but I'll put that aside for another time. So the listening workshops will help people to address gaps in knowledge of lived experiences of the residents, and things that are not usually reflected in polled data, and to build evidence around about how to build and grow this project in a meaningful way using co-production. And I must say it is at this moment in time truly meaningful co-production right across the sector. And just quickly to round up, just to say that we've developed in our dialogue, we've developed within the steering group a series of questions and principles about how we agree to work. And within that principles, it's really about being bold to have this uncomfortable conversation. As you all know, speaking about race and racism. And by the way, I should have also mentioned that we will be starting specifically with a cohort of people from the African and African Caribbean community. Then we'll be working outwards to other minoritized, not necessarily ethnically, but minoritized groups. So it started with these groups of people, and we're expecting to do the first sets of listening workshops around February, March, maybe to April next year, 2023. But in the meantime, we're going to encourage participation from the community by using various means of engagement with the community residents of Hammersmith and Fulham. And more or less, it's really the important thing is we're going to, through this listening workshop, we will be creating what's called a mandate for action. So it's a way of finding out what people actually want and what they want to do about it in order to build a stronger community. And because at the end of the day, the NHS cannot do everything on their own. We need to be working collaboratively. For sure. That's it.
Absolutely. Thank you. And the crucial thing there is you're getting people of power in the NHS and the council are going to sit down in the room with people from minoritized communities, particularly Afro-Caribbean to begin with, to hear their stories, people who we then hope can affect some change. And the distinction is that We have lots of reports about racism and nothing is done. We're trying to do something that has never happened before, which we hope will work. And it relies a lot on the NHS themselves and people of power in the council and the NHS being prepared to take part. And that is requiring a huge amount of preparation in and of itself, on top of the preparation with the residents that Sharon has mentioned. So it's a remarkable piece of work. But I think all the things you've talked about, all of you today, I really appreciate it. And I'm sorry to have driven you forward, are remarkable pieces of work. And we're obviously doing a lot in terms of consulting and engaging and co-producing, which is obviously much better than simple engagement. We've got a few minutes now. I'm going to for discussion, and Meryl's jumped in there with her hand up. Helen's next. Let's kick off, Meryl.
Right, I had my hand up earlier, but I just want to come back to the overall thing about the health and care partnership in Hammersmith and Fulham. I suspect Jim may have come back on this as well. And that is, there's obviously some fabulous work going on. We heard a lot about it tonight. The fact is most residents don't know about it. And so I've already spoken with Sue about meeting, about some of the partnership people meeting with Jim and I from HAFSON to talk about how local residents and the population can know more and be more engaged with. And I've got to keep looking at the health and care partnership because I still think borough-based partnership. But having heard some of this today, I wonder if Maria and Trish should be involved in such a meeting as well. And I think I'd mentioned Lisa as someone that should be involved for a meeting in January to talk about how we can reach out much better to the residents of our borough. And link with that, I was interested in the number of meetings. The executive meets fortnightly, and there's a large group which meets, I think it was said fortnightly, and another group that meets quarterly. None of those meetings are taking place in public.
They are in public. They're just not known about, some of them.
Well,
that's a good point.
If I haven't heard about those meetings happening, then very few people in the borough who.
No, absolutely. I mean,
so that's
they're not in public. You're right, Meryl. They're not in.
I thought it was about the integrated care partnership meetings. I got confused.
So I think there's some issues around that. I don't want to have a debate about it now. I want to raise them as issues that we might talk about to see how we can open up the health and care partnership so it becomes something that involves residents.
Brilliant. Okay. And I see that we've got in the chat, Sue says she's happy to set that up and Trish says she's happy to attend. So I think that's a good good start. Thank you. Helen.
Thanks, Ben, and thanks everyone. It's great to see all the different sectors in one virtual room, as it were. I'm one of the councillors in Hammersmith and Fulham, and I chair the Children Education Pack. I just wanted to quickly pick up on Jackie McShannon's point from earlier about children's voices and input to all the very practical and on-the-ground ways that the ICS will operate. I suggest that perhaps I might have an item on it at my committee in January, and we can kind of form an opinion, but it would be great to speak to health sort of NHS leaders as well about this. I can see people putting on me. I hope that's in response to this. So yes, we would very much like to involve as many people as possible, because this is, I think, could be a real coup d'etat of where the ICS can shine, is having children and young people represented in health, where often it's sort of slightly an afterthought. So I just wanted to seed that, say we'd love to work with all of you, and I will put together some practical next steps and have it as an agenda item for my January pack. Thank you.
And I know there are a couple of people in the NHS and Jackie will work with you on that. I think that's a great idea. And we don't just listen to people's parents, but actually listen to children, young people themselves. Jim, you're on mute.
Thanks,
you're off mute.
Thanks. As always, I'm proud to be a resident of the borough, hearing all that's really good going on, and there is an astonishing amount going on. What I haven't got, though, is a notion of the whole. Early on, Lisa said there would be a launch of the, what's I call the HCP in January. And I think it's actually quite important in terms of developing public trust that there's a high visibility for a body like this, because it looks like the only body which really will be able to influence policy way up at the ICP, ICB, etc. And it means, in practice, having a visible contact point and finding a way of bringing as much of resident energy and queerness into play as possible, because without that, what we'll have is ICP, ICB, etc. So a set of what to a resident will look like superimposed labyrinths with different entry and exit points, but no way by which a resident can actually make a difference unless you're part of a prescribed group. And I think we all want to avoid that. So
I think there's a lot of work to be done there, Jim. You're right.
But it must be, there must be a thing as well as elements. And what I'm missing at the moment is what the thing is, the shape is. A CCG had a shape, not a great one, but it did have a shape. But we actually need to think about that, because there needs to be a launch where the residents can know that really we're working with them, we want their views, it's their health that counts. And I know we've got many of the elements here, but it's that large body which needs.
I'm going to take that question, because you've got it makes me want to ask Lisa a direct question, because Lisa, you're involved in the launch and Philippa's not here today. Is the launch a launch which is mostly aimed internally, or is it a launch, because there needs to be, maybe there needs to be a second launch, which is publicity, which we do, on which we invite residents to, which we advertise on Nextdoor, where we talk about this with sort of thing that we're doing in a much bigger way than I think is planned at the moment. What can you tell us?
Yeah, it's mainly aimed at clinicians, and it's mainly internally. And take all of your points, Jim and Meryl, and there does need to be a much more visible, bigger launch as well.
Bigger piece of work. I think that's really, and Jim, we'll take that as a note from the Health and Wellbeing Board, that we need to work with the Health and Care Partnership to make sure that there's a bigger piece of work that happens, a bigger launch, so that everyone in the borough is involved. And meanwhile, you and Meryl are going to be talking about how you can be more involved as representatives of residents in the Health and Care Partnership anyway. That may be not the most perfect bringing together. Are there more questions, more comments at this time? Okay, well, I have to say you've been very, I feel.
Can I just make it clear that we're not arguing of the depth or extent of our involvement, but what we're talking about is how our knowledge over many years may help broaden the involvement of local residents.
That's what I meant. I don't think it's just. I'm not expecting you. I'm not expecting you and Jim and Maria and Trish, although you have strong, broad shoulders, to carry the views and all residents in the borough. What you can do is contribute to ensuring that we all get it right in terms of resident involvement, so we get the best policies, the best work, and the best outcomes. Maria.
I just want to echo what Meryl was saying. I think something that we've been saying for years is that it's being able to access other people. So I think, it is about meeting Meryl and Jim, but also everything we've heard about today from Joe, from Angela. There's so much going on. And when you think about where the strands can reach to now, I mean, from my point of view, thank you for letting me come to this meeting, because I didn't know it was so diverse. And I'm already thinking, well, at least I can say children, Jackie, that sort of thing. So a lot of this relationship has been so informal, so kind of a bit like the AA. I know someone who might know someone who might know someone. And I think in many ways, what Jim's saying is, how do we get that out there? And I think absolutely right. The PRG is a start, but we've also got the borough, we've got other people. So I think it's a great place to start. And I'm really happy I came. Thank you.
It's really, really nice for you to say that, and thank you. And I think that what we've come here is, first of all, this has been very rushed, and I apologise for that. I think we're very optimistic here in this borough, and we bite off more than we can chew sometimes. And what this makes me think is that we do need, outside the Health and Wellbeing Board perhaps, but the opportunity for people to come together who are doing all sorts of different co-production engagement things with residents to talk about it in a workshop format, where we can go into groups and we can come out and we can see properly what we can learn from each other. There's nothing as exciting as finding out all the things that are happening, not just in your area, but in other people's areas, and then finding the connections intergenerational or other things. So let's do that. Let's try and organise an early part of next year. When I say early, I don't mean January, Joe, but early part of next year, we're trying to have a workshop where we can come and talk about this, how we are, what's the overall term used here today? Not co-producing, but how we're engaging, perhaps even a better word than engaging, with residents. But we'll do that. So it's been very helpful. I thank you, all of you. Unless there are any more, and Bathsheba, anything more I need to say before we draw the meeting to a close?
No, Councillor, but what I was going to suggest was if I put a link to today's recording in the chat for people to access. Would that be helpful?
Today's recording of the meeting?
Yes.
And it will also be, I know there are very few channels, I know there are very few channels that people here enjoy watching us on YouTube as much as the LBHF channel on YouTube, but it will also be available there, along with the numerous council meetings, Helen's committee, full council, and anything else you choose to while away a long bath with. So thank you all so much on that happy note for coming. Really appreciate it. You're doing incredible work. Rob, thank you very much for coming and spending so much time with us. And we'd like to have you again in the future. Not forced to come to every meeting, but it's really good to have you. And there's the link I see in the chat. On that happy note, have a great Christmas, great New Year. Look forward to more fun. Thanks a lot.
Thank you.
Bye then.
Thanks, everyone.
Thanks, everyone. Happy Christmas.
Merry Christmas.